So next topic is awareness under general anesthesia. As you all know, a fundamental component of general anesthesia is unconsciousness. And when you consent a patient for general anesthesia, the expectations in that patients don't see, hear, feel, or remember anything that happens in the operating room. And the last few years, there's been an increased public concern about intraoperative awareness, and there's lots of studies that show a large percentage of patients who undergo general anesthesia and report significant fear preoperatively of awareness or recall. In the past, just regular conventional monitoring of the anesthetic depths have included some rudimentary signs such as when the patient moves, autonomic changes, and clinician's instinct. I'm not sure what that means. But a considerable effort has been devoted to establishing a monitor that would reliably determine the patient's depth of anesthesia. And several different methods have been evaluated, but none of them are 100% effective. And currently, there are at least 3 inherent obstacles in the development of a foolproof monitor for anesthetic depth, and our ability to be able to monitor to prevent intraoperative awareness. The first obstacle is that we have an incomplete understanding of the mechanism of general anesthesia. The second is that general anesthesia occurs on a continuum without a quantitative dimension, and there is considerable inter-patient and inter-anesthetic variability. Attempting to translate a conscious or unconscious state into a quantitative number can at best be limited to practice of probability. And finally, the sensitivity and specificity of a measured cortical activity may not be related to a general anesthetic induced by a chemical event within a subcortical structure. So we can hope for the numbers to relate hypnotic level, but they may not. This graph is looking at BIS values and how it relates to adequate hypnotic level. The solid line, the square, represents the ideal correlation of BIS and hypnosis. But in reality, you see the dotted line as the probability of intraoperative awareness with the specific BIS number. So, for example, the BIS number of 60, which is what technically is the ideal goal for preventing awareness, shows the probability of awareness is about 40%. At BIS of 50 means 15% probability of awareness, and to get to the 99th percentile, we need BIS in the low 20s. So just keep that in mind. And we use set line here, so set line of 50 is roughly equivalent to BIS of 60. The incidence of awareness is greater than most of us believe, because this incidence is best estimated by formally interviewing patients post-op. Patients won't voluntarily report awareness if they're not disturbed by it. In addition, memory for awareness may be delayed. A minority of cases are identified in the immediate post-op care period. And a structured interview is used to evaluate the incidence of awareness. But data are variable and controversial. In prospective studies in which there was a structured interview, it was found that intraoperative awareness occurred with much higher incidence than expected. For example, a prospective evaluation of awareness in about 12,000 patients who had general anesthesia in Sweden revealed an incidence of about 0.18%. In cases where neuromuscular blockade were used, and about 0.1% when a patient wasn't paralyzed. A similar incidence has been observed in tertiary care centers in the U.S. with a higher proportion among patients with coexisting morbidities. Studies in Spain and China have reported higher incidence, about 0.4 to 0.6%. Studies showing a lower incidence have primarily relied on quality improvement data, so retrospective, than the structured interview. The incidence of awareness is higher when light anesthesia is used, as you can imagine. So in OB patients, in cardiac patients, or patients having surgery for trauma. And the incidence of awareness is also higher in children, about 0.5 to 1%. But the good thing is the psychological sequela from awareness is lower in kids. Again, this table shows the discrepancy in literature from And as you can see, the incidence ranges from 0.068% all the way to 0.6%. That's 0.6%. That's 6 in 1,000. That's a scary number. The most common causes of entrapment awareness include light anesthesia, as we talked about, increased anesthetic requirement, or malfunction or misuse of the anesthetic delivery system. Light anesthesia may be necessary to keep the patient alive in hypovolemic or bleeding patient, people with bad heart, and patient with ASA physical class of 3 or greater who have emergency surgery or C-section or have a history of entrapment awareness have much higher likelihood of experiencing awareness. Use of paralytics prevent the most common sign of light anesthesia, when the patient moves. And inadequate anesthetized, non-paralyzed patients usually move first, as you probably have seen in sedation cases. And that's because we need lower anesthetic concentration to prevent awareness rather than immobility. Some patients, such as people who use alcohol, opiates, amphetamines, cocaine, may require increase in anesthetic dose. In addition, equipment problems with vaporizer, intravenous infusion devices may not work, your pump may be broken, and this may lead to awareness. Although these are much less common causes of awareness, especially when you use end-tidal anesthetic gas analysis. So how do we prevent it? Suggestions for the prevention of awareness include pre-medicating the patient with amnestic agents like benzodiazepine, giving adequate doses of induction agents, avoiding paralytics unless you actually have to use it, and administering at least 0.7 mg of inhalation agents when monitoring the end-tidal gas concentration. And this is important because hypertension and tachycardia don't always predict awareness, and especially people who are on blood pressure medicine, on beta blockers, you cannot rely solely on those. What about brain function monitoring? In general, devices that monitor brain electrical activity for the purpose of assessing depth of anesthesia record EEG activity. And some process spontaneous EEG and electromyographic activities, and other measure evoked potentials, auditory stimuli, etc. Most of the research concerning depth of anesthesia and all of the research concerning awareness have been performed on bispectral index, the BIS monitor. And newer monitor, there are studies behind them, but not nearly as much compared to BIS monitor. The BIS uses a proprietary algorithm to convert a single channel of frontal EEG into an index of hypnotic level, ranging from 100 in an awake patient to 0 in isoelectric EEG. Specific range of 40 to 60 reflects a low probability of consciousness during general anesthesia. Number of other events like cerebral ischemia, hypoperfusion, other drugs like neuromuscular blockers or ephedrine, or conditions like being elderly or have low amplitude EEG may affect the BIS level. So that's why it's not a foolproof method of preventing awareness. Evidence in support of a reduction in awareness under general anesthesia with BIS is derived from two main studies. One is a randomized controlled trial in high-risk patient, and another one in a non-randomized cohort comparison with historical controls. Miles and Associates did a randomized controlled trial of BIS in 2,500 patients at high risk of intraop awareness. And these were high-risk cardiac surgery patients, people with impaired cardiovascular status, trauma, C-section, chronic benzo or opioid use, heavy alcohol users, or people with history of awareness. They saw that explicit recall occurred in about 0.17 patients, 1% of patients, so 2 patients. And this was when BIS monitor was used to guide anesthesia. It happened in 0.91%, which was 11 patients, when it was managed with routine clinical practice, and this was statistically significant. And although this was a very promising result, you have to think about the numbers, because if there was only one additional patient who had reported awareness, the difference in the two groups would have not been statistically significant. And this is particularly relevant because the endpoint of awareness has no gold standard like death, MI, or stroke. Unresolved issues in these studies include difficulties in determining possible compared with definite awareness and the optimal time to interview a patient for possible awareness. Ekman et al. And compared the incidence of awareness in prospective cohort of over 5,000 patients where BIS was used to guide anesthetic. And they compared it to the historical control group of just under 8,000 of patients. They saw that explicit recall occurred in 0.04% of BIS monitored patients versus 0.18% of historical control. And this was statistically significant. But if there was another one more patient had been classified with awareness in BIS cohort and one less in the historical cohort, the incidence would not have been statistically significant. In addition, anesthetic practice may have been changed or related to BIS monitoring as well as affected by the Hawthorne effect. And Hawthorne effect, as you remember, is when people perform better when they know they are being watched. Another prospective non-randomized cohort study of under 20,000 patients where BIS was used but the values were not used to guide anesthetic depth found no difference in incidence of awareness in BIS monitor groups. In 2008, Avedon et al. Reported the effect of BIS and entitled anesthetic monitoring on the incidence of intraop awareness. Patients were randomly assigned to either BIS-guided therapy, where they maintained the BIS level between 40 and 60, or entitled anesthetic gas therapy, where they maintained it between 0.7 and 1.3 of MAC. In this study, there was no difference in the incidence of definite awareness between the two groups. And it's important to note that in this study, there was no control group of standard anesthetic practice to allow lower levels of inhaled anesthetic gas. More recently, same author did a similar prospective randomized study in a population that was at risk for experiencing intraop awareness, and this was about 6,000 patients. And they compared the two methods and came to a similar conclusion, that monitoring BIS was not superior to monitoring end-tidal gas concentration. But using a post-hoc analysis, they saw that BIS monitoring may decrease intraop awareness compared to routine anesthetic care. Finally, another study by Whitlock and colleagues, they studied 1,100 patients and found that the BIS monitoring doesn't correlate well with end-tidal anesthetic gas concentration. It is not sensitive to clinical correlates of changes in end-tidal anesthetic gas concentration and has high inter-individual variability and is not, therefore, amenable to use in finding titrating your anesthetic gases or propofol infusion. So, some key points. The incidence of intraop awareness is variable. It could be 1 to 2 per 1,000 inhalation anesthetic procedures, and the incidence is higher with light anesthesia and in kids. The potential exists for serious psychological or medical legal sequelae. Ensuring the functionality of equipment to be used to deliver your anesthetic is paramount to prevent intraop awareness. The clinician may consider administering an anesthetic agent as a pre-medication in people who are at high risk of intraop awareness. And I would argue that people who are at high risk of intraop awareness are everyone who has general anesthesia. Re-administering hypnotic agent should be on top of your head when something happens that is unexpected and prolongs your induction. For example, you take a look with your laryngoscope, you don't see anything, you call for a glide scope or somebody else tries, and in the meantime, 5-10 minutes has gone by and there's been no additional anesthetic given to the patient. That happens all the time. Hemodynamic measures are not reliable predictors of adequate anesthesia, and no monitoring has proven to be 100% sensitive or specific for determining awareness. You should monitor end-tidal anesthetic gas concentration. and consider it giving at least 0.7 of MAC of inhalation agent. And don't just give neuromuscular blocker to everyone. Give it to people who need it. And consider using brain function monitoring as an adjunct for indication of anesthetic depth. And again, don't use a single number to make a clinical decision. It's the trend of the monitoring systems that you're using. So not just one. And that will keep your patients at lower risk of awareness.